السلام عليكم. اسعد مساكم جميعا.
وعليكم السلام. هلا دكتور.
And welcome you all to this important workshop. And it's really an honor and pleasure to have Professor Abdulaziz Al-Uthman, who's running this workshop with his great experience for many years in the field, mashallah. And he's also the president of the Clinical Dietitian Society. So Professor Abdulaziz, thank you so much for running this workshop. I'm sure many dietitians and nutritionists in the country would love to be part of this and to learn from your experience. And your colleagues, Dr. Ghalia Abdin, thank you for being with us here. And again, with a great experience from Dima and the team on this dietitian. So I'll leave the floor for you, and it is your stage, Professor Abdulaziz. Thank you.
Assalamu alaikum. Thank you, Professor Ayed, for this great introduction. Actually, we are happy to work as a team in the medical field, either the surgeons, physicians, dietitians, social workers, and nurses and other part of the team. Today we will have an interactive workshop, and I'm lucky actually to be with Dr. Ghalia Abdin. She's the expert, assistant professor at Community Health Sciences, College of Applied Medical Sciences, King Saud University. And also Dima and Sally, the dietitians experts, and they will show us today some of their expertise in the field. And we will have some quizzes or polls or questions, very simple questions, just to be sure that we follow up the workshop, and we try to make it easy as possible. So Dima will give us an introduction, and she will also, with Sally, will present some cases, and we discuss it together, and we'll have these quizzes between time to time, and at the end, or even in the middle of the talks, Dr. Ghalia will highlight some information about the cases and what is the guidelines actually and protocols in this bariatric surgery patients practice. Hopefully we will have an interactive workshop. We actually would like to ask the participants to share ideas with us. They can use the chat and they can ask questions anytime. And we will be, or the team will be happy actually to answer the questions. So again, welcome Dr. Ghalia with us.
Thank you for the introductory, Doctor. My pleasure.
Let us start with Ms. Dima Rababa will start to present the cases, and Sally also will help in this discussion. And please, Dima, feel free to just let us know when we can, discuss your point. Otherwise, we will follow your, theme of representation.
Yes, thanks, Doctor, thanks to our moderator, Prof. Abdulaziz, for the nice introduction. I will share with you the slides. Okay, so I will make the share slides from my part. Is it clear for the screen?
Yes, it's clear.
Okay. For dear attendees, welcome to our workshop, Dietary Issues in Obesity and Bariatric Surgery. We are pleased to have you join us. I will try my best, me and my colleague dietitian Sally, to make it simple, beneficial, and with nice and some polls that will be paying your attention. Due to the continuing trend of obesity and utilization of bariatric surgery for treatment of obesity, our role as bariatric dietitians is essential to patient success during weight loss journey. I will call it journey, not surgery, because we do have weight loss diets followed by dietitians. So I want to talk about it as a journey, not only after surgery. In this session or in our workshop, we will follow case-based scenarios to present evidence-based approaches to dietary planning, as well as we will give you our tips and tricks from our experience to avoid diet-related complications after bariatric surgery. BMI is a simple indicator of weight for height and can differentiate between muscle mass and fat mass. BMI sometimes overestimate the health risk for adults with high muscle mass as athletes, and sometimes underestimate the risk of adults with low muscle mass, as can be occur with some sedentary lifestyle. And I would like to add something here. For the BMI criterion for bariatric procedure, it should be adjusted for the ethnicity. For Asians, overweight, it could be considered from 23 to 24.9, and for obese is more than 25. Talking about weight reduction diet plans, I didn't start with talking about bariatric surgeries. Talking about weight reduction diet plans, the availability of high caloric food has resulted in the incidence of obesity. So most of the weight reduction diets is to reducing energy intake and increase physical activity. This healthy diets, if I want to call it healthy diets, based on scientific models, some are on low carbohydrates, low glycemic index, moderate fat intake, etc. In the short term of reduction in energy intake, it is counteracted by mechanisms that reduce metabolic rate and increase the calorie intake and leading to regaining of lost weight. So that shows the cold calories in, calories out model is outdated. We have poll for the attendees, Dr. Rahman. We have like 30 seconds for our attendees to put their answers, please. What are the main causes of obesity? What do you think are the main causes of obesity? Is it overweighting and overeating and less physical activity, genetics, medication, and or psychological factors, or multifactorial? Yes, most of the questions are answers, are multifactorial. So obesity is not only due to one reason. Thank you for your answers. I will continue my presentation. Prof. Abdulaziz. Prof. Abdulaziz, are done with full one. Yes, again. So obesity is not only due to one reason, it's multifactorial, as most of you answered this poll. So obesity, some are related, the causes of the reasons for obesity, some are related to endogenous reasons or factors, talking about genes, hormones, metabolic rates, and others are exogenous factors like video games, television, elevators, sedentary lifestyle. So when dealing with obese patients, we should be aware that the reason is not only due to increased food intake or reduction of or increased exercise. Some are endogenous that are not able to be changed easily, or it's difficult to change them. Others are exogenous that can be controlled. So please don't, as the dietitians, we do not judge the patient. Weight regain is a common problem. And again, no judgment, telling the patient it's because of your lack of commitment. We need to understand the body physiology, that the body will compensate its weight loss, and the body is considering it as a disease. So weight loss is difficult, but maintaining the weight loss is a greater challenge. The success is how to maintain our weight loss. Sally, if you want to add something here regarding the notes we give to patients during our clinic, talking about what is the reason and why they are gaining weight or they are not achieving their, maintaining their weight at the one they lost?
Well, the note is mostly for dietitians. Even if your patient had all the means to lose the weight and they didn't, it's never our job to judge our patients. We should always be of help to them and show them that we are actually on their side, not against them. This will only do is elaborate the problem and make it worse. So showing them we're on their side will actually help them achieve better results in the future.
Thank you. So going to biological, yes, doctor, sorry.
Yeah, I think I may add an important information here. As we say always, listening to the patient is a major factor for a successful treatment or management, as we say. So identifying the real problems for weight loss barriers, for example, can make us better individualize the dietary plan or dietary management plans for them. So I just want to add it and stress on this point as we always speak of. Thank you.
Yes, thank you. So talking about the biological response to weight loss, the normal response of body to weight loss is more likely to gain weight. This is simply because your body is fighting your weight loss. After weight loss, our body reduces the formation of endogenous satiety hormones and increases the hunger hormone ghrelin. This will compensate and affect the satiety hormone on the opposite, that the person starts to eat more. He wants to have more food. He will have increased appetite, even if the patient on medication that suppresses the appetite. Patient will think that he will develop a plateau because the patient reached the equilibrium. So this physiology must be understood, well understood by the dietitian and the patient to help us deal with it. So we have to deal with the obesity as a chronic disease management, not as acute disease management. I will read this for you, Sally. Case one, patient has a long history of dieting and weight cycling, type 2 diabetes. For the last 6 weeks, she has been working hard to follow a healthy, low-calorie diet and improve her exercise habits with regular follow-up visits to the dietary clinic. Her reward was watching her weight go down and feeling better. Now, however, for no reason can be identified, the scale has stopped budging. She hit a weight loss plateau.
Okay, first of all, the first thing you need to do is explain to your patient that weight plateau is normal. Of course, at some point of our weight journey, the weight will be somewhat, as patients call it, stuck. I'm not seeing results, the scale is not moving. Well, here we will go as the patient sees it. We will talk to our patient. We will figure out how the weight plateau is actually caused. Is it actually due to the diet? Are the patient consuming too much sugar? They're not working out, or their workout routine is kind of not doing anything anymore. That's different. Of course, doing a labs to make sure we have no anemia, their thyroid is working just fine, will also be great. But start always with explaining that it's normal. Sometimes weight plateau is just a body response, as Ms. Dima said before. Sometimes actually we have a lot we can do to help the patient. But in the end, it's normal.
So weight curve plateau is normal for weight loss to slow and even stunt. And sometimes this can be followed even by weight loss surgeries. So we have to understand the reason, and we have to give explanations and or to give tips and tricks for our patients just to change this kind of the past plateau they have. We can reassess your habits and dietary intake. Maybe sometimes it's due to lack of sleep, stress, hormonal problems, dehydration, constipation. For the ladies with the age of menstrual period, it could be a reason, and they have to be patient. Now, after talking about this, just general talk about diets and weight loss and the physiology about that, and how to lose weight, we go to operational options. So the criteria for bariatric surgery, we have inclusion criteria, exclusion criteria. We have general guidelines we have to follow, and this depends on the patient's situation and the surgeon decision. We have another poll. For consideration of bariatric surgery, all are inclusion criteria except body mass index, BMI, more than or equal to 40, failure of non-surgical weight loss, well-informed, compliant, motivated patient, uncontrolled severe psychiatric illness. Okay, this is right. Most of the answers were uncontrolled severe psychiatric illness. Back to the slides, please. Just problem moving to the slides. I need to go to another second slide. Full. Yes. Okay. Back to our workshop. Types of bariatric surgeries. We do have restrictive procedures that limits the amount of food consumed or the feeling of fullness. We do have malabsorptive procedures that limits the amount of nutrients absorbed by bypassing the stomach or in the small intestine. And we have combination procedures. Another poll, please. I have poll number 3. Yes. Appropriate management for prevention of vitamin mineral deficiencies after Roux-en-Y gastric bypass includes all the following except 200% RDA vitamin mineral daily, 500 milligram elemental calcium as calcium carbonate, 500 microgram sublingual vitamin B12, total of 50 to 100 milligram elemental iron for menstrual women and or patients with anemia. Yes. So the answer actually is the calcium as calcium carbonate because they need the RDA, the 200% RDA, the 500 sublingual vitamin B12, and the iron. I would like to commend Dr. Ghalia for talking about this because it has to do with the malabsorption technique, and the calcium is not affected by bypass.
Sorry, I was muted. Sorry, say it again, Dima. I didn't hear.
Their answers were mostly that they didn't follow the right answer. Okay, they give us the answer as A, and it is the correct answer is B.
Yeah, definitely they have to have it. That usually these types of surgery, especially the bypass surgery, thus it is a metabolic surgery. It has a malabsorptive part of of it due to the anatomical changes that changes the physiology of the body when they start absorbing this micronutrients. So yes, they do need to be supplemented with a good supplementation when chelated very proper. Yeah.
Thank you, doctor.
Anything to add from your side?
No, that's it. Okay, so back to the workshop. Gut hormones and their role in bariatric surgery. Well, bariatric surgeries lead to profound changes in the secretion of gut hormones with effects on metabolism, appetite, and food intake. These changes places weight loss and the gut hormones in key position actually with respect to metabolic improvements after bariatric surgeries. Nutrition care of bariatric patients. The role of bariatric dietitian here is responsible for the nutritional care of bariatric surgery patients. Plays an important role in every aspect of care, from pre-operative assessment to the long-term evaluation and monitoring. Another poll. What component care process is used by practitioners to obtain, verify, and interpret data needed to identify nutrition-related problems, their causes, and significance? Is it nutrition diagnosis, or nutrition counseling, nutrition assessment, or nutrition education? I'm just waiting the number of attendees to be all voting. Okay. Right, nutrition assessment. This is right. Back. No, it didn't work. Yes, okay. Nutrition care of bariatric patients. The nutrition care process of the bariatric patient is to improve actually the consistency and quality of individualized care for patient outcomes. The 4 steps to the nutrition care process for the bariatric patient is nutrition assessment, nutrition diagnosis, intervention, monitoring, and evaluation. Would you like to add something here, Sally?
Yes, just remember, your process for any patient, not just bariatric patients, should be tailored based on your patient. Patients come from different ethnicities, backgrounds, ages. You should always make sure it's tailored to your patient's needs and background so that you have the best results.
I think, Lima, we may add a point in here if you make me, please bring me back. I think as we see it in here, usually to have a proper diagnosis, you do really need to concentrate and be having a real proper assessment with gathering and pulling in the needed information for that. Having a proper diagnosis moves you to a good intervention that is tailored, as Sally has said, on the patient's need according to the guidelines or international guidelines or even the national guidelines that have been accepted by the associations and the ministry or whoever works for logistics in that. And of course, having a good nutrition intervention will move you to the 4th point, that is having a proper close monitoring. After monitoring, evaluating and re-evaluating your cases, as this is a long-term follow-up. I don't want to say treatment management for a patient. You're having a totally new patient after having suffering from that much years or months or whatever from obesity, and having their disappointment with diet, and then get them to get operated. So they need to live a new lifestyle and manage their anatomical changes and new physiology and metabolic changes that has happened to their body, other than what they have been used to live with. So I think, I mean, all patients maybe sometimes uses to feel, yeah, we lost weight, so we don't need any more to follow up with a dietary clinic after a year or two, for example, especially if they have reached their nadir weight, for example, and just rebounds a bit small amount of weight. But the problem is that the shown result is weight reduction, but no, there is a massive amount of electrolytes or micronutrients, etc., that is hidden behind this intervention or nutrition monitoring and evaluation. So a good dietary team or a good multidisciplinary team would maybe work on motivating the patient that yes, you've got your results from the weight reduction, but yet you have to take care of a healthy body, a good quality of life, lasting for inshallah forever. And not to mention that there are some countries, especially, for example, we would say in our country or in our region, they do it at a young age, 20s, 30s, and they're not yet married, maybe not yet getting children, you know, the whole journey after the surgery.
And even adolescents, doctor.
Definitely, and definitely shading on adolescents, we do have a young age generation in general. And we do have the problem of obesity, a remarkable problem. So yeah, thank you.
Okay. So we are going to, before surgery, nutritional evaluation of pre-surgery for patients. We have to help patients resolve vitamin and mineral deficiencies and correct blood glucose levels, provide nutritional counseling for pre-operative weight loss, nutrition education about lifestyle changes, including healthy choices, structured meals, snack patterns. Physical activity is very important. Here, the patient is supposed to have knowledge from the dietitian what will happen after surgery. They have to know it's not like a period of time that you are going through surgery and you go to your normal lifestyle. You have to change totally your eating habits, your lifestyle, and you have to follow a very good pattern so you can be losing your weight and maintaining it without any poor dietary, let's say, outcomes. Because even after surgery, if we didn't reach our goal or our desired weight, or we lost much, or we regained weight, this is also poor outcomes. So they have to know that they have to have a very good nutritional evaluation before surgery. They have to have the good knowledge what they have to do after surgery. A pre-surgery weight loss, what do you think? Consistent data supporting a beneficial impact of pre-operative weight loss on the long term. So it will help in reduction in operation time on average of 25 minutes shorter, shrinking of liver, but it also perpetuates the weight bias and affects the set point. So we have to be selective to whom we need to do the pre-op weight loss, and it is mostly by the suggestion of our surgeon. So here, according to the case, sometimes it's given like a chance for patients, especially the young patients, to have like weight loss before going to surgery. It could be a step forward, not to follow a bariatric surgery. They will try, sometimes they are coming insisting to have their surgery, but maybe they are not candidate for that. So it will be given as a kind of reducing your weight. You can be able to reduce it before going to surgery. But in general, we don't go in unless our surgeon suggested for special cases. We have a poll. Management of blood glucose before bariatric surgery is important to to what? Sorry. Reduce the risk of post-operative infections, promote weight loss before surgery, or promote wound healing. Well, actually, it could be all of the above. Only. Okay. It could be more than one answer, by the way, but it reduces the risk of post-operative infections, promote wound healing is mostly the good answer. Post-operative nutrition care. So we have really two periods here for the post-operative nutrition care of bariatric patients during the first year after surgery has two distinct phases. From 0 to 3 months post-surgery, we lead patients through the post-operative diet progression. We help them stepwise since day 2 of surgery and before, of course, that we mentioned pre-operative. We monitor and help prevent early nutrition complications or side effects. Sometimes it could be related, cannot be controlled, or it has to do with the patient following instructions. Help patient implement a vitamin and mineral supplementation regimen. And the other period, we have from 3 to 1 year, and we do guide the patient in essential lifestyle and behavior changes to support continuing weight loss and weight maintenance. Post-operative diet progression, we follow stepwise, take a baby steps from gradual steps, starting from clear fluids to normal food intake. We try new food one at a time and gradually replace liquid calories. Immediately after surgery, all procedures have the same stages. It's for safety, avoid complications, promote healing. Clear fluids, cold fluids, pureed food, soft food to maintenance or reaching to the normal food. This depends on the institution or the patient tolerance, actually, number one. Number two, the doctor experience or the surgeon experience and or the institution or hospital protocol. We have a poll. The first stage in the post-operative diet is clear fluids, and it should only occur after the patient has successfully passed the swallow study to rule out any surgical complication. The purpose of this stage is to provide hydration to the patient, stimulate GI motility, prevent gastric ileus from occurring. Okay. Okay, it's mostly the stimuli GI motility. Thank you. Okay, I will go through these because we are all aware what are the clear fluids as a dietitian, as attendees listening to this workshop. We do have a stage 1. I'm not talking about the duration. As I mentioned before, it depends on each hospital protocol. We have clear fluids that according to the tolerance, 3 or 1 week. Then we go to full fluids with good hydration. Here is the goal: adequate protein intake and good hydration. We help the patient to give them good options and to do kind of changes, not on depending on one kind of liquids. Here we do have case study, Dr. Ghalia.
So it says that your patient is consuming a full liquid diet, stage 2 in the diet progression stage, as you have said, after undergoing a laparoscopic sleeve gastrectomy 10 days ago. Now, however, she states, the patient, that she is only having 1 meal per day because she found a protein supplement providing 6 grams protein per serving. So what's your advice?
Ali?
Okay, so the first answer here, have you seen the quotation marks around the word meal? This is your answer. there is no meals in fluids. Patients should always be hydrating and consuming fluids. So we need to emphasize this multiple times, that you are not having meals, you are constantly drinking. I like to say to the patient two things. Imagine you're sipping coffee all day, or if you remove the IV drip, you are the IV drip now. So always make sure your patient knows that they will never be able to drink one huge gulp at once. So the only way we can go is for them to keep hydrating by actually really imagining them drinking coffee all day. We will make sure we avoid all the early complications like not needed fatigue, nausea, and we will make sure that the gut is moving so we can actually go to the next stage.
Okay, I have to add something, another message for our dietitians as attendees. Here, it's not the options allowed for the patient to take, it's the technique how to drink is most important. It's how to drink and the amount. We can give him the list of allowed and non-allowed options of food or fluids, but they do not know how to drink. Like I can say apple juice, okay? They can have a cup of apple juice with no water intake. The technique itself has a very important role here to overcome their complications or the early fatigue they feel after surgery, because they've been fasting before surgery, going through the day of surgery with the pain, and then go clear fluids and step to the full fluids, and they are not still aware of the technique itself. This will cause the other complications and side effects they will suffer afterwards, and they keep on thinking that they are passing days to reach to normal solid food. They are going to like counting days just to go to that step, but they have to overcome all these steps so they can reach their goal. Based on literature, there are metabolic advantages from ingesting a 25 to 30 grams of protein distributed throughout the day, including maximum stimulation of muscle protein synthesis. So going pureed food, also we have to concentrate of water intake and how they separate their food intake. And when now they're having semi-solid food, so they have to be aware also of drinking the required amount of water, covering their protein, daily protein, and starting a bit more exercise. Stage 4 is soft diet with the now mostly near to normal eating habits, 3 meals, 2 snacks, covering their also protein intake and what are options. And we have to remember also the vegetarian patients, what good options they have to be given, like to over or compensate their needs, because they need from 60 to 80 grams of protein per day. And for the adolescents, 90 grams per day, reaching 90 grams per day. The bariatric dietitian should advise the patient regardless of whether they are hungry or not. Their diet plan is a nutrition prescription. This point must be followed. They are not eating because they do have reduced appetite directly after surgery. So we have to cover their needs. It's a nutrition prescription. It's a kind of medication. They have to cover their needs during the day. Now going through quickly, because we have to discuss more and highlight on case studies more, because this is what we have in clinic. I just go past through those post-operative supplementation protein recommendations. It's to maintain body mass, to promote healing, minimize hair loss, and as I mentioned before, 60 to 80 grams for pediatrics, reaching 90 grams of high bioavailability protein sources. Micronutrient supplementation. Why? Because sometimes we have pre-op deficiencies, depending on the kind of type of surgery. Is it restrictive, malabsorptive, or combination? We have also the patients will avoid certain foods because of maladaptation, so that we have to give them supplementation to cover their needs. This is the general needs after surgery. Some available vitamins here in the market are chewable, other are tablets. That depends on the patient tolerance. Multivitamin, multimineral supplements in the early post-operative period, recommended to take 2 to 3 multivitamins chewable to optimize their absorption. And then as food intake increases and healing occurs, we allow to reduce the multivitamin per day. And this depends on the follow-up visits to the clinic. Long-term bariatric diets, we have to follow these basic principles: protein first, healthy lifestyle, frequent water intake, adequate supplementation. We always have to remind the patients with those main basic principles within each visit. And this is what we do during our assessment. We have to hear from the patient before going through the other step. Sometimes correlating information taken from the patient himself, you can find their problem, because they sometimes think this is normal. I thought this is their main answer. I thought this is normal. I thought it's not important to drink this amount of water. I thought it's not important to take my protein shake frequently, and so on. So we have to listen, correlate, and explain to the patient why we are taking this and what will affect your health or your body or your weight loss as a main goal.
If I may add,
yes, doctor.
From our observation, I've heard this a lot, that protein comes first. It depends really upon the type of protein, if they like it or not, the sweetness or not, if the aftertaste or not. So it's very good to have a variety to lead them to use any of them. Plus the misleading information sometimes on the social media, they do mix up the information. Yeah, the medical information with other information. So a frequent water intake, I think all of us know that they keep on saying that they don't like water. It doesn't taste good. So it's very good to give them an option. If we can flavor the water or something with any healthy, like a mint or whatever, and icy, maybe they like it a little bit cool. Now the supplementation, surprisingly, they do really ignore the whole story of supplementation. They do, maybe because of the commitment thing, I don't know, maybe they don't like it, and then they start complaining of hair loss, nails, etc. Where I've seen really good cases that were compliant enough with the supplementation during the first and second year. Believe me, they didn't have any problems regarding their hair or nail or kind of fatigue or something when they follow the hydration program, the supplementation program, the protein in a way. This protein thing, sometimes they come after a couple of months that wasted, and they're not doing this exercise, and then they start complaining from a psychological point of view that they're not feeling happy with their body. So it's very important maybe to gather all information all together and take the experience of the patients and let the patient know about it from the dietitian herself. These are really, and I'm sure you guys, Sally and Dima, because of the your clinic have a very good number of patients and you've seen a lot of it. So I think these points are really important not to neglect in our dietary journey with the patient.
Yes, thank you, doctor. And we have to always add other options, alternatives, give alternatives for each and explain why. They think that it is optional to have protein or no to have, and they think directly regarding adequate supplementation. They think since or once we started with normal food intake, so I'm covering my need. They forget directly that we did restriction of the size of the stomach that cannot be having all your needs per day. So you will not reach your adequate needs. This is supplementation, added value for you, so you can make it to be healthy looking and no complications after surgery. We have protein options, maybe food sources, and it can be modified or added, because only per se protein sources from food is not enough for bariatric patients afterwards. And their frequent water intake, we do give them much examples, like change the company, look for the sodium content, add some flavors, do something to hydrate yourself so you will not go through complications after surgery. And most of them is hydration. I make it general here, the minimal dietary recommendations: protein 60 to 80 grams, and for males will be more. Carbohydrates 50 to 100 grams, complex carbohydrates. For the total fat 20 to 40 grams. We actually do not, in our practice, make it in grams. We give them general to make it easier for them, because it's not practical for patients to follow and calculate one by one. We have another poll. Okay. Common food intolerances. This is a very easy question. Common food intolerances of the bariatric patients include meat, bread, and yes, of course. I would like to add something here after the end of voting. Yes, rice is the most common food intolerance, but the problem is the dryness of food. For some patients, anything dry, hard, they are not tolerating it. People or attendees who answered ice cream, maybe they thought of intolerances in the first period, like milk intolerances, okay, or fruits, that hard fruits. The question is supposed to be like telling that the patient after passing these stages and with regular food, he is not tolerating the meat, bread, and rice. Just for a tip given from our clinic is bread itself, it's not tolerable by our patients, but if make it dry as a rusk, it can be tolerated. As soft food, it will stick or stuck in the stomach, so they cannot tolerate and they avoid eating bread. Bread or carbs, it is needed, and sometimes they feel that we have a lot of food options that we cannot tolerate, so they feel depressed. I can't eat bread normally as before. All they have to do is make it dry as a rusk. It can be tolerable. 3 to sure, this is the okay, sorry. 3 months to 1 year post-surgery, patients are ready now to follow a healthy, lifelong of nutrient dense, minimally processed whole foods to promote weight maintenance. A patient should follow a structural meal and snack plan of 3 meals a day with 1 or 2 snacks if needed. Patients' eating speed and portions must be monitored at the stage to promote weight loss and weight maintenance. Here, they started normal life. I don't want them to forget that you are a bariatric patient. You have to follow the amount, the portion written, covering all food options from all food alternatives. They have to have a scheduled day covering their needs, following them. Sometimes most of them write their 24-hour recall or what we call food journey, just to make sure that they are covering all their needs. Their exercise, they can start from our practice. After 2 months of surgery, they can start gradually going to the gym and doing more exercise rather than walking. Quick poll. Your patient is 4 weeks after Roux-en-Y and complains about chronic fatigue. Which of the following choices is least likely to be the cause of her or his fatigue? Is it inadequate protein, dehydration, inadequate calories, iron deficiency? Some answers are changing. Okay, from my point of view, I would say inadequate calories rather than inadequate protein, because their protein intake is supposed to be taken and somehow it's not leading to fatigue. They have a general inadequate calories. Sally, do you have any comment here?
Well, always make sure that your patient is not fasting. Okay, they always believe that, oh my God, I'm not eating now. This is a good thing, and
Yes.
I shouldn't be eating. There is this stigma about bariatric surgeries that the less you eat, the better, and that's actually the goal of the surgery. No, the goal of the surgery is to help you change your eating pattern. Your body does not work with prolonged periods of fasting. It should be always 3 meals, snacks when needed, and make sure you emphasize on this on the first early stages. to make sure we don't have any complications post this period.
Maybe I do have a question in here.
Yes.
I've heard about also these patients that used to have some, irritated because of some food, for example. They didn't follow maybe the guidelines properly. They ate a little bit much bigger portion. They threw out, they vomited, and then they started avoiding having such foods or meals, kind of afraid of having such feeling again. So, and it turns to them avoiding meals and avoiding snacks and avoiding this. I think it's like kind of like, I don't want to say it's a psychological thing, but yeah, I mean, the brain starts telling them, no, avoid, don't take it. And of course, with what has Sally said now, with a big picture of eating less makes weight loss even faster and quick to reach the goals. So how would you deal with this?
Well, I will deal with some foods. Sorry, I will answer and then I will give you the floor, Sally. From my point of view, I will explain why you didn't. It's how you presented the food for your new stomach now. The problem is how you presented the food to your own stomach. Now you have to look for another way of introducing it. So sometimes I will deal with the meal itself or the food, the item that they dislike it anymore or causing irritation or intolerance as allergy, as dealing with allergy. So just avoid, and then we stepwise, like some patients as the full big four, they don't like rice at all. They avoid eating rice. Okay, but I told them, if you have this traditional Saudi food, salik, it is tolerable. Okay, if you eat like risotto, it's fine. So the way you introduce the rice itself to your stomach, this is why you refused. It has to do with something else. When you listen to the patient, how is their daily food intake? You know that there is a big duration between each meal and another, leaving their stomach kind of dry. So when introducing rice directly or something dry directly, and they will be hungry because no food intake for a long period, they will they refuse to have it, and they directly vomit. And this will be discussed now with one of the case studies. Your opinion, Sally.
Okay, they compare themselves to the first 2 months. They've lost a significant amount of weight and they couldn't eat. They were barely finishing their pureed food. And when the actually wound is fully healed and they start going to regular food and they do not feel pain when they're eating, they think, oh my God, I'm eating too much, I'm gonna gain weight. So they're mixing up the feeling of the stomach healing and adjusting to food with them actually doing something wrong. So they start to get afraid and then they stop eating thinking, oh my God, as there's something wrong with me, I'm gonna go to my surgery to fail. So it is actually somewhat psychological and you cannot blame them. All we can do is figure this out early and make sure we comfort them and tell them how they're doing well and this is normal and we are actually proud of them for starting to eat better, not more, better food quality.
Yeah, I think this needs maybe, as you said earlier, close monitoring for that. And maybe trying to understand the learning mechanism in our brain, how it works for this shift from before surgery to after surgery, and that it's not maybe for good. I mean, even if they're not tolerating rice for this period of time after surgery, it doesn't mean that they're not going to have it maybe or try it after a year or a year and a half or etc. Just to make themselves happy, getting it back to their system if they just wanted it to come back to their system. So yeah, thank you.
Back to our presentation. What I have seen in our practice post-bariatric. This is mostly for the years I've been working with bariatric patients. This is what I've seen in my practice in the clinic. And this could be, some of them are because of the early stages and the other of the late stages. Okay, so we have a lot of things to talk about. And even dealing with it, we don't have one treatment for each. It could be combination of more than one plan. So I will give the floor now for Sally for the post-operative nutrition complications, talking about starting with nausea and vomiting as an early side effect of bariatric surgery. And this is mostly what they suffer after surgery, what they complain day 2 of surgery.
Okay, this is the first thing they go to. That's the first complications they experience, and you have to go to them and the first day trying to see how they are doing, and they're giving you the sad look. Oh my God, I'm vomiting. I haven't stopped. Is this normal? Yes, nausea and vomiting are very normal. Well, you see, but there are some things you need to notice about nausea and vomiting. In the first few days to the surgery, it's very normal. You can help your patient by doing 3 steps. Make sure you teach them how to breathe. Inhale and exhale deeply and smoothly. This will help the stomach kind of relax. Make sure they're drinking in a 45-degree angle. They're not drinking and laying down, or even drinking while they're laid down also. And they should never drink and walk at the same time. Always give yourself a 5-minute break in between. This will help alleviate some of the nausea and vomiting in the first few days of the surgery. Now, later on, nausea and vomiting might be because they tried a new food, the food is too heavy, or anything of these causes. Sometimes it's normal, and sometimes it's induced. The patient is forcing themselves to vomit. This can actually be, it's not their fault. They've ate something heavy. They didn't ingest their food well. They're not chewing their food well, or they are doing the biggest mistake we see. They are eating and drinking at the same time. And this is very common. There should always be a 30-minute interval in the middle. What we can do is ask the patient, how did the vomiting happen? Like, did you lose control over your stomach and suddenly you're vomiting? Or did you feel like you couldn't breathe and you had to push it out so you feel comfortable? This way, how you induce between induced and actually involuntary vomiting. Both have different cures. Okay, induced, of course, you have to teach them how it's wrong to induce the vomiting yourself and how to avoid the problem in the first place. Involuntary, make sure they're tolerating their food well. There is no gut problem. This is actually be with you communicating with your doctor well. Make sure there is no gut problems and your patient is also the same, following the same guidelines. Chew your food well. Don't eat too fast. You are the first to sit on the table, the last to leave the table. No drinking and eating together, and small bite sizes. Your bite size should be approximately half your bite size before the surgery.
Okay. Go to dehydration.
Dehydration. Well, there is always a war in our clinic with the patients, whether it's me or Ms. Dima, with water. Please drink your water. We actually started testing different flavoring.
I have to add something here. The patient coming to my clinic without holding their water, they know that they will be punished. Okay, some patients coming saying, I forgot my water at home. My question will be afterwards, did you forget your mobile at home? So
no, actually, your patients, when they come to me, they come with a water bottle because they were expecting to see you. So they're like, you see, I have my water now. They're not drinking, they're just afraid. So you see, I have my water. The thing is, you cannot really blame them. They feel like water is thicker than other fluids, so they can't feel it going down. Making it colder, making sure they're actually separating throughout the day. I always say, carry it around with you. You don't forget your children at home, do you? You always carry your baby from room to room. You're carrying your baby and your bottle. This is your baby now. You're stuck with it.
And that depends on the patient itself. Sometimes when you are talking about young, you have to make it fun for them, like
colorful water,
putting numbers on each bottle or putting each different flavor on each bottle. If you are talking to old ladies, you have to tell them correlated with the prayer time. Whenever you hear a prayer, you have to open a new bottle. And that depends on the patient. You have to make it easier for them.
I started to play with them again. Whenever you look at the water, you have to drink a sip. And this actually fixed a lot, because the brain will always take a mental note. Oh, I have to look at the water. So they will be drinking more. Now, making sure the water is cold. Sometimes if low sodium water, add better. Flavoring the water with the artificial flavors like the sachets, or actually just putting fruits or herbs inside the water will do the trick. Okay, and it's a habit they need to build. Sometimes they have no problems, they just forget, which happens to all of us. So carrying the water around will help you drink more.
And sometimes they combine the amount of water to be drunk is when they are thirsty. It has nothing to do with thirst. You have to drink even before getting thirsty. Your lips supposed to be moist. Your urine color is supposed to be light, and you have to go to the bathroom more than 4 times urine only. This is the good indicator for you drinking water. Some people, you cannot tell them you have to drink 1.5 liters, 2 liters, 3 liters. Your body will speak out how much water you need.
You know, one of the tricks that I found it not that useful is I mean, buying a special bottles that has the amount of, for example, per se, 150 liters, 1.5 liters per day, just divided into a blue and white, red and yellow, green and white. So make them like half their day, they have to finish the red one, and the other half they have to finish the yellow one, and then they have to, you know, because I've seen that making themselves mixed up with the same bottle with the family really makes them forget it. So maybe, as Sally said, a mental note that this bottle and this bottle has to be finished. Flavor it with the way they like it. Add mint. Arab people, we do love a lot these stuff like cucumbers, mint, herbs. You know, our food are all made of these stuff. So maybe they have to find with their dietitian the proper way to finish the water at least, and not take it, because really some of them, they just don't even reach the small bottle of water, the smallest. So yeah, it's a challenge.
Some patients, they like the small one to keep it cold.
What I was saying is the al-hafidha, I mean, that keeps the coolness or whatever. I mean, anything that makes them just drink it. It's a great challenge. Yes, I believe so.
Fatigue or general weakness?
Okay, fatigue and general weakness, again, in the first few days, it's normal, nothing to worry about. However, when it's too much, when the patient cannot even lift their body, this is a good indicator of water. You know, we always say if you're not drinking enough water, you can always notice their eyes are sunken in and it's turning a bit darker. They're having a bit of dark circles around their eyes and some darkness around the mouth, and of course chipped lips. This is a good indicator of poor hydration, and this is where we go into the water war again with them. Also fluids, sometimes they actually miss their fluids for meals, or they're not, oh my, she wasn't being too serious when she said all the time. No, I was being serious, I was not joking. All the time, you're the IV drip now. When they are actually staying for like 2 to 3 hours with no calorie consumption, they start to feel fatigue due to the low calorie. I mean, fluids will be burned by the body very easily and very quickly. We always need to replenish what we lost. So this is your first indicator what your patient is doing. If they're not drinking enough water and they're not drinking enough fluids in the first few days, fatigue is the first sign for you. Later on throughout the month and throughout even the years, low energy is usually due to, as we said before, low caloric intake. The patient is fasting for prolonged periods of time. Sometimes their meal size is not good. Their meal options are not actually something that will keep them really energized throughout the day. Like they're using juice instead of a meal. They're drinking, like they're taking a piece of biscuit instead of actually a breakfast. That will mean that they will be good in the first few hours in the morning, and then they will start losing their energy. Sometimes they're not taking their vitamins or they're anemic. Making sure to run your doctor, actually not you, will run all the necessary labs are great, and make sure they're taking their protein shake and they're consistent with their vitamin and their drinking intake.
Yes, but here I have to add something. Sometimes when they feel that they are losing weight and they're happy with the scale, they are, or sometimes having intolerances with some food, they are ignoring having their meals, leading to fatigue. You reach your goal, but you are still fatigued. So this is a poor result. So you have to be adequate food intake, feeling active and healthy, and this will lead sometimes to depression because they are afraid of having their food. They feel depressed directly. They don't know why they feel depressed. They're supposed to feel happy after weight loss and after surgery, returning back to normal food. But the point is, this is the role of the bariatric surgery itself starts when you go back to normal food intake. In the beginning, you have to go through stepwise stages. It's not because to lose weight. Anybody can follow this diet and lose weight, but the challenge is when you go back to normal food, because at the beginning it was for wound healing. Now it's your habit. This is your stomach amount. The surgery, it did only amount, controlling the amount of food. You have to have your meal, even you don't feel that you like to. This is the note given by the diet to the dietitian each time. You have to remind them how important to eat. It's a nutrition prescription. And they feel before surgery, they have very high appetite of food. After surgery, with reduction of appetite, they feel this is the success. No, it's not. It's how to deal with food and food intake. Okay, talking about loose stools or diarrhea, this is normal actually after surgery. It could happen because most of them are constipated patients in our clinic, but some have loose stools because of the changing physiology of the stomach or the GI, or due to drinking a lot of sugars. Most of patients they don't go through all options they have. They only depend on water and juices. So excess sugar intake, or it could be due to lactose intolerances. So they have to the treatment plan is to hydrate, dietary adjustment, limit their sugars, and they sometimes we give to the doctor as an opinion to give them antidiarrheal medication. But they have to be aware of drinking water because it has a lot of causes. Is it early loose stools or at the late stage? It could be dumping. It could be using alternative sugars like diet sugars, making some kind of sensitivity or allergy they are not aware of. Constipation, same point, because we have limited food options in the beginning. We stop sugars and we stop fibers, no fatty food. So changing the physiology of our stomach again, low fiber diet, this cause, and the narcotic painkillers, this can cause constipation. Some patients here, they have misleading term telling that we have constipation, but they do have a late emptying time because no solid food entering their stomach. They feel, oh, I'm constipated. No, you are not constipated. It's a matter of time because you are depending now on liquids. Either it's clear fluids or full fluids, nothing heavy to pass the stools. So just give yourself some time. We have to give them food options with good fibers according to the stage, hydrate well, move, active, and maybe sometimes they can have kind of laxatives to move their motility. Hair loss, this is expected. We have 2 stages of hair loss. In the first week, it's because of anesthesia, and then it is like expected to have hair loss after surgery. The advice here, we have to do preventive notes or plan given to the patient to avoid this hair loss. It could happen, we have to be clear, from 2 to 4 months. This happens because of the poor food intake before surgery, and now good nutrition, number 1, vitamins for the hair, eat your protein sources and protein shakes, take your supplements, and water. Again, water again. Dehydration is very important, and it could be one of the causes because of protein malnutrition or general food intake, the poorness of their food. We have a poll now. Your female patient is 7 months after sleeve gastrectomy and is complaining of hair shedding. Which of the following is the least likely to be the cause? Is it iron deficiency, surgery stress, inadequate protein, or essential fatty acid deficiency? Okay, the question was which of the following is the least likely to be the cause? because she passed 7 months. So surgery stress is not the answer. Okay, we've passed already the stress of surgery. Although the one of the hair loss causes is stress, emotional stress. It could be a cause too. We have to be aware of this one. Okay, Dr. Ghalia.
So case study number three, your patient is 1 year and 3 months after bariatric surgery and states that he is struggling with increased hunger, both with and between meals. His weight loss has stabilized. What would be most important strategies for him to be doing to prevent weight regain?
Okay, so you see, this is actually, again, the same point. Patient is leaving too much time between their meals. They're not hungry, so they feel like, why should I eat? I just got breakfast and I'm gonna have dinner at night. That's more than enough. And sometimes even the meal distribution itself is bad. So they're having like 2 scoops of potatoes and they think that's, yeah, that's lunch, that's good. Very poor protein servings usually is a big cause of this. And also no good quality snacks, or even sometimes no snacks at all. This is where we actually have to help our patients understand this will cause the weight to stop going down. The body will start to get into, no, I'm not getting enough, why should I burn? So they start seeing no results, their weight is plateaued, and they're not losing any more weight. Once they start actually going to the recommended regimen of 3 meals per day and snacks when needed, we usually say if you're going to stay more than 5 to 4 hours between meals, to always have a good snack on hand. Good snacks are usually low in calories, around 150, high in protein or in fiber, and low in sugar. And regarding the weight regain, you see, when they start going through this regimen for a prolonged period of time, hunger starts to kick in again. They're not as happy with the 2-meal regimen anymore, but they cannot tolerate food anymore. Like, they're very used to the small amounts of food they're eating. They can't even have a good meal. So they start to compensate by having high sugary foods. Sweets usually are the first to go to option. It's for them, it's easy. It's not causing me any pain when I eat it, and it's fast and it's available. Sometimes to go to things like chips, it melts in your mouth, so it doesn't require digestion. This is very common for long-term patients. This is when we start seeing the weight going back up again. It's really sad because they're not eating. They don't understand why they're gaining the weight. They're not eating. They're just having snacks. But their snack is all sugar, juice, sweets, chocolate, anything that melts or requires minimum digestion is very easy for them. And they start unconsciously sliding into the scale. What we do is always, I'm not going to tell you, leave sweets, no, don't eat sweets, do not do this. We're going to go to a concept called crowding out. Crowding out means I'm going to give you way too much good things to focus on. There is no good room for the bad things. I'm not saying sweets are bad. We don't demonize food, but too much of anything is bad. So we're going to focus again on having consistent meals, making sure we're dividing our meal correctly, good enough protein, good source of carbs, good source of vegetables, anything that's heavy. We usually, however, recommend do not have green vegetables with your meal. This is very important to stress because they will not be able to eat it. So a good cooked in food, vegetables, good protein source, and a good source of carbs. A simple breakfast, do not go overboard, good enough and hefty dinner to keep you full, and lunch also in the middle, that's not too much. Make sure you're also tailoring this to your patients. Sometimes healthcare professionals, for example, they cannot eat during the job. They're in a hospital 24/7. They are actually the one we see this pattern with a lot. So I always say, okay, get your breakfast, get a piece of fruit, and take a protein bar with you to work. And when you go home, then you can start eating your dinner or lunch, because they will start eating fast and they will have problems. So they will just skip and then live on coffee and dates until they finish their trip. So tailor this to your patient, make sure they're having enough meals, make sure they know how to distribute their meals, and make sure they are limiting their sugar intake and they understand why they're going through this pattern.
And this is why the importance of the following up visits for the patients to keep them back on track. Sometimes they just leave the track and they have some struggling with other problems. That's why following up visits is very important to keep them on track again.
Yeah, let me highlight something in here. Sally, you said that they might be avoiding the protein foods such as like meat, fish, and chicken per se. And we do use really to know about it that maybe mechanically it's hard for their stomach, especially the first, And then they do divert to less. They will be looking like a nibbling style. I mean, every 2 hours, like having such things. So this is another behavior that they might even also create. And when they don't come to the clinic, it goes like for a year or two, and then they start coming back when they start that looking at the weight that has been stabilized or going up. Juices maybe is a point. Other drinks, for example, might be of high calories as well, might be a point. Now, I believe in something as well. I don't know if you do agree upon or not. We do as individuals, some of us are sweet eaters, some of us are not. I mean, so before surgery maybe, and this is when the research has been highlighted this point, and I did my research on the rewarding area of the brain. There are, I think, watching up the patients before and after, and watching up the maybe having ourselves in the multidisciplinary team with the surgeon and the medical team. Maybe it's a good valid point to be aware of this earlier to even the surgery, because so far as having it as a metabolic surgery research until now, we do need larger and longer surgeries. But yes, the wanting reward area in the brain is changing after surgery so far, as well as the early results of the consummatory is the liking, if we say we want or like the sugar and fatty stuff. So it's a challenging thing, right? Here. So how can we just get them, and how can we just really solve this in between things? They might not be wanting it so much from a research point of view, and from the clinical point of view, we might see that some of them are just having it more even frequent because they are avoiding their intolerance. So a solution in between this area has maybe to take place, because this nibbling behavior, you may talk about it more, but are you seeing it frequently or not?
Actually, yes, I do. And I think if I'm not mistaken, the research says snackers and sweet eaters have shown to have lower results and have shown to have actually higher chance of regaining weight. And actually, I've learned this from you, Doctor, if you remember. So it's correct, actually. What we can do is actually start from the beginning. When we started introducing them to food, we started with meal pattern. We always start with meals. If they're having their meals, even if they're sweet eaters, they cannot, there is no space. We try to limit the space they can snack on as much as possible. And we actually started to reinforce this information before. Why we are limiting your sweet intake, why are we preventing the snacking, why are we doing all of this, is because we do not want you, I always tell them, I do not want to see you 2 years after this. Okay, if you come here, I'm not going to say you're being kicked out, because if you develop this, we can actually reverse this behavior. And if we did this correctly, we're good, we're set.
I think human beings are an adaptable creature, so maybe we can work it hard a little bit on ourselves. But yeah, it's a challenging thing, I think.
There's another point here talking of sometimes if they like to have sweets before surgery, they dislike it after surgery. Okay, this is another challenge too, because they dislike, they don't like to have something sweet, even if the, for example, protein shake with the artificial sugar, they feel it's very sweet, they cannot tolerate anymore. So we have to look for options. That's why dealing with each individual patient alone and hearing from them before surgery and after surgery, and what way they will pass through and what they have to do afterwards. And again, the follow-up visits are the very, very important for the good nutritional assessment.
I think bypass surgeries, I'm sure surgeons will talk about it better than I do, but maybe I think this dumping syndrome thing, I mean, we do see it maybe in sleep gastrectomy, but not as much as the bypass. Maybe this makes it even a help, actually, that makes them learn to avoid sweetened food or high sugary food.
This is the benefit of dumping syndrome.
They will end up by unpleasant symptoms. So they start thinking once or twice. Maybe it's the human being. If you're not hurt of something, maybe you want
it's being annoying for them. This is the benefit of dumping syndrome. Sometimes they feel it's a benefit. They are happy to have it for most of the patients. Yes. Go back to post-operative nutrition assessment, types of food and fluid consumed, timing of meals, energy, fluid and protein intake, vitamin and mineral supplementation, identification of food cravings and food intolerance, proper advancements to diet stages. This is, I just simplified what Sally said. Post-operative nutrition diagnosis, we had selected the nutrition diagnosis for the early post-operative periods from 0 to 3 months after bariatric surgery and 3 months and to 1 month after bariatric surgery. So this is in general the important things and signs and symptoms. We have the nutrition or problem, let's say inadequate micronutrient or supplementation intake, inadequate protein intake, inadequate fluid intake, swallowing difficulty, alerted GI function. This is from 0 to 3. This is the early stages. This is what they suffer and the symptoms and how we do the treatment. And we start and we do the following through mobile, even if they are not able to come to the clinic. We keep on following them. What happened? What did you do? Improvements? How did it go? This is the reason for that? And one of the patients, like they come just say, I have a problem in protein intake, and that's it. So he tried maybe dry fish or dry chicken, and then he's not tolerating it anymore. So we have to make it modified according to his food stage, even if we return back 3-4 stages backwards until tolerance to overcome this problem or nutritional complication. After 3 to 12 months, we have a lot, but excessive energy intake. This is what we talk about weight gain or weight regain or weight plateau. This is due to actually happens here not after 3 months, maybe more. Because when they are used to normal food, solid food, and they are now clever enough for their choices and how they eat the dense calorie foods, that it's a small amount according to the pouch size, but it increases their weight again, or they return back totally to their before lifestyle, okay, before surgery. Any comments, Sally?
Okay, so you see, this is the 1 to 2 years is the period we actually see the weight regain in. You see, patients after surgery do actually have a natural aversion to high-fat food and any heavy foods in general. But sometimes what they feel is like, I am missing out on my friends. They're going out. I have to pretend to eat. Or I did not tell patients I'm a bariatric patient. So they start to actually test the water, as we say. While after a while, oh, I can't eat this. Let me try to eat more. After a while, the quantity builds up and the stomach actually, it's a muscle. It learns to go even farther. I mean, they keep pushing it to go farther. This is when it comes to actually eating higher calories with eating higher quantities. And again, we can eat high calories without eating high quantities by going to sweets, juices, things that are very small but have extremely high sugar content.
You know, Sally, I think it's the main challenge, or one of the main challenges, is having the patient before surgery, during and after surgery at early stages, as well as prolonged, to understand that surgery is not a miracle. I mean, it's not a button that we just
a helping tool.
It is a helping tool. I used to say that it's like when you want to cross a road, you hold the hand of your child, for example, you cross the road, but he has to go into the school through the gate, main door, etc. He has to work it out. He has to spend some energy thinking and walking and carrying his bag or his lunchbox, etc. But I just crossed the road with holding his hand and put him out into the near the main gate, I think. So this is maybe this is one of the important points, that the mindset of the patient, all of us, we're human beings. All of us want the quick fix. We want the easy, easy go and quick results, etc. So maybe having all this together, these are maybe the main challenges to make your patient, and of course they vary. Some of, as human beings, we vary. Some of us are more compliant, some of us are less compliant, some of us, we have our own fears, etc. Depends on the culture and the education, etc. So I think altogether we have to not miss that it's not only a dietary information, I mean pure dietary information. No, how to apply it, or how to be compliant doing it, and how to maybe manipulate this thing according, or tailor it according to the types of people. This quick fix thing is a challenge.
Yes, it's a very big challenge. Also, they have to be aware, also our patients, that what you did is, as you mentioned, doctor, it's a helping tool for you, and you had this opportunity. So continue for your lifelong the effect of this bariatric surgery. You have to depend on yourself. The surgery, what it did is the amount of food eaten is less, whether is it a restrictive or malabsorptive or whatever kind of surgery he's been through or been through. Something else, we have to work on exercise. You have to drink water much. The stress and the quality of sleep, all these are combinations together to have your desired weight, and you keep it maintained, because this is the success itself. It's not just a number in your scale that the one you like it. You know, the poor outcomes of the dietary outcomes of after surgery, it could be weight regain. It is or too much weight loss by the patient, or he didn't reach the desired weight expected. So all this together, and once they start gaining weight, they do not want to change their lifestyle. They want another option. Give me another, I will redo surgery. I will go for pharmaceutical solutions. Give me something. They do not want to change. This is very important also. So these tools. You have to do something by yourself to help your body understand yourself. By all means.
I'll just add a quick point here so we can move to the other slides and case studies. Having myself that I really don't like this, putting them in such categories for surgical patients or patients with obesity or patients who did the surgeries. We ourselves, or any person who has a normal body weight or a slightly increased, if we don't watch or we don't pay attention, we will also fall in a trap of gaining weight. So it's not a matter that people who are having this problem, we're not stigmatizing over the surgery after or before the surgery, but it's a general thing. Me myself, if I just like start eating and not thinking of it, or not exercising or not moving, again, I will fall in this. So I think it's a general thing.
For any person, the weight itself, or overweight, obesity or overweight, it's not their fault, but it's their responsibility.
Exactly.
It's their responsibility to work on that.
And this has to be clear to patients or to people with high weight or surgery, so they won't fall into the behavioral or psychological things that we are like this, or we have this problem. No, we all have this. Please.
Okay, Dr. Ghalia.
Again, case number 4, your patient is 17 months after surgery and complains of dizziness, irritability, lightheadedness, and in the late afternoon. Now, your patient has no history of diabetes and blood pressure is within normal. What is the most likely the cause of these symptoms and best course of action?
From my point of view, we have to look after 17 months. That means he's on regular food for a long time. He has these symptoms afternoon. That means at the end of the day. So for now, I think it's kind of maybe low blood pressure. It could be kind of low blood pressure, or it could be for dehydration, or not, or long duration between each meal and another. He's making like long duration. Could be a cause. So that's why I think we have to again do a nutritional assessment in a good way to help him or she, he, I don't know, the patient itself, to know how to eat well and less stress, hydration, frequent meals, less stress, and maybe it could be do general control of blood pressure. Yes, it's a low pressure. Yeah. It's most likely. Or it could be late dumping. Yes.
Maybe I would add the point. Maybe it should be command. Maybe definitely they will go to their medical team. Though these people who were on the blood pressure medication, maybe, or cardiac, or it has to be fixed, maybe, or rearranged in a way that may also a cause of. You never can tell. Yeah. So it's a low blood pressure.
Yeah.
Mainly.
And this could be late dumping. Yes.
Late dumping.
This also can be seen, and you should take note of this, people who don't eat well and actually exercise because they're sweating too much. This is also the electrolyte imbalance. It might be simple, but it's very, very severe for them. And they do feel the same symptoms we are mentioning here. So if your patient is not eating well, not hydrating well, and working out at the same time, they will feel the same. This same case will be represented again. We can fix the exercise part only by like having a big water bottle, a small squeeze with any citrus, and a dash of salt. We'll fix it throughout the workout. However, the original problem, the big problem, is not fixed. We will follow what Ms. Dima said to fix the original problem, but just make sure if your patient is working out and complained of this, that he might be lightheaded because of this.
Okay. So case number 5, again, your patient is 5 weeks after gastric bypass and complains of low energy, frequent vomiting. 5 weeks. Okay, her vomiting happens every 2 to 3 days and is not necessarily associated with any kind of food, maybe. So her fluid intake consists of 2 protein drinks of less than 2 cups and 25 grams of protein each, and 500 ml water bottle. She claims she can tolerate chicken breast, mashed potatoes, raw or cooked spinach, and frozen yogurt, but avoiding most other foods for fear of getting sick. And she takes 40 grams of Nexium, kind of omeprazole daily. And what is most likely her issue is? Dima or Sally?
This could be.
Before you answer, just we have to be aware of the time. 8 p.m. Okay. We have to finish our session.
Okay, so this actually we go now straight to eating habits. Make sure she's chewing her food well. She is actually having good small bites when she's eating, and she is not drinking when she's eating. She might be tolerating the food itself, but the way she's eating is not working. Also, make sure she's not having anything that's annoying her stomach in the beginning in the first place.
Good, but it's good that she's complaining of frequent vomiting, because some patients, they are happy with the vomiting, okay, as a diet disorder, because they are happy that they vomit, they eat and they vomit. Some patients, they having as a kind of eating disorder, which is good that she's complaining of this vomiting. It's annoying for her. So the point is dehydration. Yes, the fact that she can tolerate certain food rules and ulcer and bowel obstruction, she's getting more than 50 grams of protein, but only less than the 5 cups of fluid per day. And she confirmed that her urine is often dark yellow. She must be counseled to increase her fluids up to at least 7 to 8 cups per day.
Okay, perfect. So case number 6 says, I had gastric sleeve 2 years ago, and I'm now having this problem of constant, non-stopping burping, which is, For the last month, I was in the emergency room 2 weeks ago with painful bloating. I passed gas and I was released after 2 nights in the hospital. I don't know what is causing this burping since I'm not eating much. I quit coffee and dairy products since I was told that they might be a problem. I'm so stressful since I recently got a new job. And I also have a back pain and I am able to pass gas.
Okay. So in this case, we're gonna go 2 ways. First of all, we're gonna treat their symptoms. Usually, we can actually help with this. Natural antispasmodics like mint and cumin will help with the bloating, especially if it's severe. Walking will also get rid of the air even faster. Now, the prevention, usually what got the air into the GI tract in the first place was eating too fast. Patients who eat too fast, they're gonna get air into an already, and not too well, they will get air into an already small pouch. The air will keep pushing up on them and it will be causing severe bloating there for them. Also, we can avoid foods that actually cause bloating, like beans and foods that are known to be gases in general.
Yes,
Okay.
and also to avoid treatment to prevent, again, repeating this problem. Just when we do the treatment, we just inform the patient that it's a preventive way to prevent doing it again, not return it
to
back
solve the
again.
problem once and for all.
Is it a common problem?
Chew well and smaller bites when you're eating.
Is it a common problem at the clinic? Is it a common problem for patients? Yeah.
A lot. We have that kind of burping or regurgitation. Yes, and they have the problem of having this noise with in the social. It's a social problem too, because they don't know what's the problem. Most probably it's because empty stomach. It's full of gases, and whenever they start eating, they say it's connected with eating. Whenever I start eating, I can hear this kind of burping or regurgitation that's embarrassing in front of friends or family. So mostly they don't know what to do. So the most important thing here is to avoid long duration between meals. Drink water. Don't make it more than 2 to 4 hours. Chew well. Don't eat fast. And this is the most important thing. Some are due to irritable bowel syndrome, like having colon problems. They have gases. So this is supposed to be treated alone. And as a bariatric patient, they have to be aware what to do. This is very common in patients eating too fast, as Sally mentioned. Eating slowly and in smaller bites will help avoid this problem. Avoid the gas-inducing food and limit the use of straws and chewing gum too. Using natural antispasmodics like cumin and mint will help alleviate the symptoms.
So going to the 7th, I'm 8 weeks post-sleeve gastrectomy. I had my first foamy experience yesterday night. I ate some tender fish, about 4 or 5 bites, and I guess I ate too fast, and for about 2 hours, I had foamies and pain. I tried to throw up, but nothing will come out but foam. What is the foam for? Actually, it's a question for you, ladies. And where does it come from? I've even tried sticking my fingers down the throat. I mean, just the aeration to just throw up, but it doesn't work. Maybe seems to move up stuck parts.
Yes, this is actually something called foamies, which is somewhat very common also. You see, yes, but okay. So usually sometimes patients have a larger bite than they think they can handle, and it's not chewed very well. The first word they're gonna tell you is if they feel like it got jammed inside and it's not coming out. This is where they start to force themselves to vomit. They try to get it out, and it's a whole hassle, and they start walking laps around the yard until they can finally actually manage it. Now, the first thing you're gonna advise is never try to vomit on your own. It's gonna get results on just, and do not drink water to help make it better. It's gonna only make it worse. You're gonna vomit everything you just had. So no drinking to help it go even smoother. And don't try to force it to come out. It's not gonna come out if you force it to vomit. You're just gonna hurt yourself. So this is the first conversation you need to have with your patient. The other one is how not to happen again. You see, the answer is in the question itself. Please make sure you're chewing well, you're having small meats. Do not, it's not a race. Please make sure you're taking your time eating. Again, you're the first to sit on the table, the last to leave the table.
And it could be due to empty stomach and the stomach secretion. Okay, stomach secretion will be there, and being long time no food intake, and whenever they start eating quickly because of long duration, again, this foam will show up in the beginning.
Maybe I think this happens to maybe working, I mean, people who are at a job and they come just late in the evening, just they crave food and eat too fast, and this happens again to them. Maybe could be a reason.
Yes.
Okay, so a woman aged 43 years presented to her general practitioner with intermittent episodes of dizziness, sweating, physical fatigue, desire to sit for the past 4 months. Right? Yeah. These episodes last for a few minutes and resolved spontaneously after lying down. Lately, these episodes have become more common, especially after sugary meals. Now, she had no chest pain, breathlessness, or lost consciousness during these episodes. Her medical history included an anxiety, asthma, type 2 diabetes, obesity, for which she had undergone gastric bypass surgery 2 years ago. She was a non-smoker. Her only medication was escitalopram, 2 milligrams daily. Her clinical examination was unremarkable. Vital signs were normal. Her body mass index was 32 grams per meter square.
Okay, so most probably, I think it's kind of dumping syndrome, but it's delayed dumping syndrome because her symptoms seem so as a kind of hypoglycemia. It could be due to hyperinsulinemia, in which the body used to deal with the big mass. Comparing, the body is usually dealing a lot of sugar, but it's actually the patient is taking small amount. So I think it's kind of dumping syndrome. We do have early and late dumping syndrome. The early abdominal cramping, bloating, nausea, sometimes diarrhea, palpitation, sweating. But in her case, I think it's most probably is the hypoglycemia with late dumping syndrome. The treatment is we have to tell her that she's supposed to rest, hydrate, treat her hypoglycemia in a way, and she's supposed to be monitored, educate how the causative factors for this patient and the appropriate food intake, how it's supposed to be taken, and explain what happens mechanical, the dumping syndrome, why she's supposed to avoid these things, and this is normal happening. So it's a dumping syndrome with rapid gastric emptying after a meal. It's classified as early and late. Early dumping syndrome presents with 30 minutes of a meal. And as I mentioned, the symptoms with the late one, it occurs after 1 to 3 hours. And it's due to hyperinsulinemic response. This leads to reactive hypoglycemia, which presents the androgenic and the neuroglycopenic symptoms such as tremor, sweating, anxiety, fatigue, hunger, and confusion. Dumping syndrome usually happens in both, as you mentioned, doctor, before, and bypass more than sleep, but it happens in sleep. Her lifestyle and dietary modifications supposed to be treated. Smaller and more frequent meals of low-calorie dense food, a high-fiber diet of unprocessed carbohydrates, and low glycemic index. Other dietary modifications include avoiding liquids, 30 minutes of solid meals, avoiding simple sugars, and providing with high-protein, calorie-dense foods, and increasing intake of protein.
Great. So we may take the ninth case and then move to the questions of the attendees.
Yes.
So, sorry. So a 24-year-old male came to his 4-month follow-up visit, and he started to feel like a burning sensation in his stomach each morning. And he said that this has started 2 months ago and is gradually getting even worse. Now, after conducting a simple 24-hour record, recall, I think. For patient, we found that he is skipping breakfast and just grabbed an Americano and cigarette on his way to work. So he starts his day with caffeine and cigarette smoking. Nicotine.
I'm gonna give you a life-saving tip as a dietitian. Whenever you hear the word heartburn, just ask, coffee before breakfast? Usually the answer is yes.
The answer is yes.
And when we tell them you cannot have coffee in the first period, they die. They give me the look like, you are an evil person. How can you say no coffee? And the first thing they do when we allow coffee, and then they start their breakfast. At first, it's not gonna do anything. It's gonna be normal until like one day they wake up with severe heartburn. They cannot breathe. They feel like there is acid burning all their esophagus and their stomach. The first thing we need to do, unfortunately, cut the caffeine for a while until the feeling subsides. And of course, no smoking before breakfast. Like, you cannot judge people and tell them not to smoke. Let's be realistic. But we can tell them when to have it for their own safety, of course. So drink water when you first wake up. Make sure you have your breakfast first, or even at least a piece of fruit, and then you can have your coffee. If you cannot tolerate coffee immediately after the surgery, start with something you like a cappuccino or a latte, something with milk on it. You can use milk substitutes if you cannot tolerate lactose, but just don't have an Americano as your first coffee experience after surgery.
Coffee is allowed, but not in the morning, not in the beginning of your day.
Coffee is not a meal. Your meal should not be in a cup.
Yes. Yeah. I just want to end up with this one: rate of weight loss in the first year after bariatric surgery. We have many factors that may influence the rate of weight loss. It's preoperative weight, height, gender, abdominal fat distribution, physical activity, food and beverage choices, medical status, and medications. It is important that the patient understand that weight loss occurs in stages with periods of loss followed by weight plateaus. The goal is to lose weight in the healthiest manner possible, not as quickly as possible. We would like doctor to go for some questions and answers of the attendees. So we have Saleh Falah here.
Yes.
Budur, I don't know. He's with us. Thank you, Saleh, for attending. Budur Mullah. So for decreasing the hunger of bariatric surgery patients, they only have to eat 3 meals and snacks between them if needed. Is this a question?
Well, I believe from your presentation, it says, and we believe that, yeah, the more that they live on a pattern, maybe a flexible pattern somehow, but they would save this, I think. Having themselves, maybe they waiting for 1 meal or something, it wouldn't really help at all. You can add your points as well. I think adapting the nibbling thing increases hunger, I think. And cutting off the meals to 1 or 2, again. So as we say, al-wasatiyya is the best thing. Having their pattern, as you've said, Dima, from your experience at the clinic in Sally, I think, yeah. And sometimes I think they miss it in between hunger and thirst.
Yes.
Do they? I don't know. Maybe sometimes.
Yes, sometimes they didn't drink that. That's why we have to ask them the first question. Are you drinking your water needed per day?
Because hunger should be less after surgery. I mean, from if we can follow from a literature point of view, hunger should be better, especially if we follow the hormonal changes that has happened after the surgery. But as well, maybe these tips that they will follow from your clinic or from the guidelines would help a lot of this. I don't know if you do have any other additional points that I've missed.
We have another question. What kind of exercise would be recommended for the patient post-op? Are patients with cardiac issues have any exceptions? Well, from our protocol, doctor, from our protocol, we do follow just walking in the beginning, in the first stage after bariatric surgery, just walking, and it could be divided during the day, and then at the end of the stages, it could be continuous 1 hour. After 2 months of the surgery, they can start gradually going to gym, attending classes or doing endurance exercise. That will be gradual. Regarding the cardiac issues, it has to do with their cardiac issues and the permission taken from their doctors, and they can do the exercise that it's fair enough with their situation.
Exactly. I think, yeah, the guidelines as much as possible in this. And of course, we do have our colleagues at the multidisciplinary team that they are expertise in the physical activity and exercise. They would work it out perfectly for rebuilding or maintaining their muscle mass during the first and second year of surgery, and having it as a habit created on, as you said, starting with walking, gradual increase, and definitely for cardiac issues, it's the call of the medical team with our help, of course, and the help of the physical activity team in particular, exercise.
Yes, Saleh is asking, is he's thanking the presenters and telling which is better? Is it the bariatric surgery or the plastic surgery or liposuction for weight loss?
And to be honest, this should be a question to the surgeon himself. But Anna, I will take the, lead briefly. They are totally different. I mean, plastic surgery is not a solution for obesity. Loss. Yeah, for obesity or even morbid obesity. So they're totally different. They're totally different.
Yes,
obesity,
it's just for body contour. It's body contour, and it has to do with the specific BMI. It cannot be done with very high BMI.
I mean, to lose weight and to have a better physiology and healthy body and healthy and even the comorbid conditions won't be solved with the as per my knowledge. For the plastic surgery, it's only just like you're minimizing some of the fat in some areas, but it won't make you definitely get rid of the obesity.
I think we are almost on time. It's 7:55. And thank you for the attendees. Thank you, Dr. Ghalia, for participating and make it fruitful workshop. It's very nice to having you join us. Thank you. Dietitian Sally. Any note you have to tell for the attendees or the dietitians, bariatric dietitians, anybody?
Well, as a note, just make sure you're actually, again, this is a tailored approach. You're a dietitian. We all know that we have to go easy with our patients, never judge, always be friends. There's something I think we all learned is how to have a good relationship with our patients. Listening comes first, and then your approach to your patients. That's all.
I would thank you so much for such a beautiful workshop. I enjoyed it a lot so much. Thank you, Sally. Thank you, Dima. You made it so interactive, and I think we all are at the service of patients with obesity, and we're always looking into always making it easy, helpful, understanding. The most important thing to make them feel at ease with a good quality of life, regardless of who has been lost weight more, X, Y, or Z. Some neighbors I know from their friends, why did she lose 50 and I lost 30? Yeah. And why did I lose 30 and she lost 60? And why did he? And you know, it's definitely individualized. And thank you so much for having me. It was my pleasure.
Thank you. And we have to know always that we do learn from our patients. It's not only from literature, we do learn from our patients every day, and we have to know how to deal with them. Psychological point of view, dietitian is everything for the patient after the bariatric surgery. Nevertheless, the doctor's job and the surgeons or the medical team, but as a part of multidisciplinary team, the job of the dietitian is very essential. Thank you all. Thank you, attendees, and we wish to see you in another workshop. Thank you all. Thank you. And thank you, SASMBS, for this nice work. Thank you.
Thank you for the kind invitation. Thanks.
Why, Sarah? Hello, assalamu alaikum. Thank you so much for the really great discussion. I can see very good participation from the team. I see 53 attendants. So thank you for your workshop, and looking forward, inshallah, for your collaboration as part of SASMBS, inshallah, in the next annual meeting, all of you. Thank you, Ghalia. Thank you, Dima. Thank you, Sally. And thank you for Professor Abdulaziz. I know he has another talk he's presenting somewhere else. So we have your contribution of a great value in our society today. I appreciate it. Thank you.
Thank you, Doctor.
Ending this.